Imagine taking a daily pill that practically guarantees your breast cancer won't return.
Right, the ultimate goal.
But in exchange, it essentially ages your skeletal system by decades, and it spikes your body temperature by like 15 degrees in a matter of seconds.
Yeah, it is a really intense trade-off.
Today, we're looking at the ultimate medical double-edged sword. Usually when we talk about a medical intervention, there's this expectation of a clean transaction. You have a diseased appendix, the surgeon removes it, you heal, and you just go back to your life. The narrative we're often sold is that the cure is, well, a finish line.
It's a very linear expectation. We crave that visible resolution. But you step into the world of oncology, specifically breast cancer survivorship,
Yeah.
and that clean narrative just completely fractures. We are looking at a post-treatment landscape that is, quite honestly, a massive hidden endurance event.
Welcome to your deep dive. If you've ever looked at a friend or a family member undergoing maintenance therapy for breast cancer and wondered, why they seem so exhausted long after the chemotherapy has ended, this is exactly why.
It's exactly.
Today, we are unpacking how life-saving endocrine therapies for breast cancer fundamentally mimic, trigger, or dramatically worsen the symptoms of menopause. We're looking at the mechanics of this medical balancing act, and we're drawing from clinical oncology data, the latest NICE guidelines, and some incredibly powerful patient accounts to do it.
And to really set the foundation for you, we have to look at the clinical reality first. So around 80% of breast cancers are hormone receptor positive, or HR positive.
Okay, 80%. That's a huge majority.
Right. That means these cancer cells are essentially using naturally occurring estrogen in the body as their primary fuel to grow and multiply. So the medical logic is pretty straightforward. To stop the cancer from coming back, we have to cut off the fuel supply. We just have to stop the estrogen.
But estrogen isn't just hovering locally in the breast tissue, right? It's systemic. It is everywhere in the body, communicating with your brain, your bones, your joints.
Everywhere. Yeah.
Removing it, or blocking it entirely, plunges the body into a sudden, intense menopausal state. Surviving the cancer is really only part of the battle. The other part is surviving the cure.
That's a good way to put it.
Okay, let's unpack this. Before we can truly understand the severity of these symptoms, we have to map out exactly how these drugs are altering the body's chemistry. Looking at the clinical guidelines, there are two main approaches. Let me try an analogy here.
Okay, go for it.
If estrogen is a physical key, and the cancer cell has a keyhole that turns on growth, a drug like tamoxifen is essentially like putting a piece of duct tape over that keyhole, right? Like the keys are still circulating in the blood, but they just can't get in to turn the lock.
That's close. But it's not just passive tape. It's actually a bit more dynamic than that. Tamoxifen is what we call a selective estrogen receptor modulator, or a SERM.
It's the SERM. Okay.
Yeah. So in the breast tissue, yes, it blocks the receptor, but it's an active modulator. In some tissues, it blocks the keyhole, but in others, it acts like a skeleton key itself, basically mimicking estrogen. We'll get into why that matters later, but you're right that it doesn't destroy the estrogen circulating in the body.
Ah, okay, so it's a selective blocker, not just duct tape.
Precisely. But here is the critical distinction. The other main class of drugs we see in the oncology data are aromatase inhibitors, or AIs. These are medications like anastrozole, letrozole, and exemestane.
Right, I've seen those names in the sources.
Yeah. So if tamoxifen blocks the keyhole, aromatase inhibitors essentially burn down the key factory. They stop the production of estrogen entirely.
Burning down the factory, I mean, that sounds like a systemic shock.
Oh, it is a profound shock to the system. And the biological mechanism of how it works is quite elegant, even if it is punishing for the patient. You see, in postmenopausal women, the ovaries aren't the primary source of estrogen anymore. But the body is resourceful.
It finds a way.
Exactly. It still produces small, vital amounts of estrogen by taking androgens, male hormones, and converting them into estrogen. This conversion process happens out in the peripheral tissues, like in the fat and muscle, and it's driven entirely by an enzyme called aromatase.
So the body basically finds a back door to keep a baseline of estrogen flowing.
Right, and aromatase inhibitors go in and explicitly block that specific enzyme. They shut down the back door. Because of this, AIs drop the estrogen in a woman's body to levels far, far below what she would ever experience in a natural age-related menopause.
Wow.
And we should also factor in ovarian function suppression drugs, like goserelin. These are used in premenopausal women to shut down the ovaries entirely, causing an immediate medically induced menopause literally overnight.
So whether you are using a skeleton key blocker or burning down the peripheral factory or flipping the main breaker switch on the ovaries, you are fundamentally starving the entire body of a hormone it has relied on for structural and chemical balance for decades, which naturally brings up the physical fallout. If the body is suddenly starved of estrogen, what is the immediate visceral reaction?
What's fascinating here is how the clinical data captures the most visible side effect, what we typically call a hot flush. The medical...
Wait, I have to stop you there. I really want to push back on the casual way we use the term hot flush.
Oh, absolutely.
Because, hot flush makes it sound like you're just feeling a bit warm in a stuffy room or you wore too many layers. But looking at the neurology in this data, it's not just sweating. It is a severe central nervous system malfunction.
You're absolutely right to call that out. Society tends to diminish it, but the clinical term is vasomotor symptoms, or VMS. And the underlying mechanism is a profound neurological event. When you withdraw estrogen so abruptly, it causes a severe defect in the central thermoregulatory function located in the hypothalamus.
The brain's thermostat breaks.
Exactly. Specifically, the lack of estrogen throws off the balance of critical neurotransmitters, mainly norepinephrine and serotonin.
Your brain literally loses the physical ability to gauge temperature. I was fascinated by the stats on the core body temperature neutral zone. Normally, a healthy human body has a neutral zone of about 0.4 degrees Celsius. It's this tiny, comfortable window where the brain says, we're good, we aren't sweating, we aren't shivering.
Right. And without estrogen acting as a stabilizer in the brain, that 0.4-degree neutral zone narrows down to become, as the clinical literature literally described it, virtually non-existent.
A virtually non-existent neutral zone. Think about what that actually means for a second. The brain is constantly miscommunicating. Because that buffer is gone, the hypothalamus suddenly panics. It thinks, we are overheating, we are going to die. So it triggers extreme peripheral vasodilation to dump the imaginary heat.
And the data shows just how extreme that vasodilation is. The body throws all the blood to the surface of the skin to cool down. The temperature in a woman's fingers and toes can spike by 10 to 15 degrees Celsius in a matter of seconds.
10 to 15 degrees in seconds. That is a massive, violent, physiological overreaction.
It's incredibly aggressive. And then, because the body just dumped all its surface heat to combat a fire that didn't even exist, the core temperature actually drops.
Oh.
The brain suddenly thinks it's freezing to death, which triggers violent chills, shivering, and clamminess. Up to 80% of women on tamoxifen experience this cycle. It is the central nervous system malfunctioning on a continuous loop, sometimes dozens of times a day.
That sounds completely exhausting. You can't regulate your own environment.
You can't. And if we connect this to the bigger picture, estrogen isn't just managing the thermostat in the brain. It is a foundational structural component for the physical architecture of the body. When you strip it away, the entire physical house goes into shock.
Right, which takes us from the brain's thermostat straight into the structural integrity of the skeletal system. Let's talk about the bones. I like to think of bone health as a constant, never-ending home renovation project.
Okay, I like this.
You have these cells called osteoclasts, which are essentially the demolition crew. They go in and tear down old, brittle bone. Then you have osteoblasts, which are the builders, laying down fresh new bone. Normally, estrogen acts like the site manager, keeping the demolition crew in check so they don't tear down more than the builders can replace.
That is a perfect analogy.
Yeah.
And when you remove the site manager, when you plummet estrogen levels with an aromatase inhibitor, the demolition crew runs absolutely wild. The osteoclasts begin destroying bone tissue far faster than the osteoblasts can ever hope to rebuild it.
Wow.
Because AIs completely deplete estrogen by shutting down that peripheral conversion in the fat and muscle, they lead to heavily accelerated bone loss.
And the data on this isn't marginal. We're talking about a massive structural vulnerability. Women taking AIs face a 2 to 4 times higher risk of bone loss and fractures compared to a woman going through a natural age-appropriate menopause.
2 to 4 times higher.
Yeah.
If we look specifically at the spine, the relative risk for vertebral fractures nearly doubles. The clinical data puts the relative risk at 1.84.
Almost double the risk of a spine fracture.
Yes, this is precisely why osteoporosis is such a massive primary concern for these patients. It's so severe that patients often have to go on entirely separate classes of drugs like bisphosphonates just to protect their skeleton from the collateral damage of their cancer medication.
Here's where it gets really interesting, though, because looking at the oncology data, there's a bizarre paradox here. While aromatase inhibitors are acting like a wrecking ball to bone density, Tamoxifen actually does the exact opposite in some cases.
Yes, and this loops right back to your duct tape analogy earlier. Remember how he said tamoxifen is a selective modulator? It's a SERM.
Right, the skeleton key.
Exactly. It's a brilliant nuance of pharmacology. In breast tissue, tamoxifen acts as a strict antagonist. It blocks the estrogen receptor, stopping cancer growth. But in bone tissue, specifically in postmenopausal women, it actually acts as an agonist. It structurally mimics estrogen.
Wait, really?
Yeah. So tamoxifen actually protects the bones. It steps in as the new site manager, keeping the osteoclast demolition crew in check, and slows bone loss.
That is wild that a single pill can just, know which tissue it's sitting in and act completely differently based on the local environment. Though I did notice in the guidelines that there's a caveat, tamoxifen can cause slight bone loss in premenopausal women.
That's true. Because premenopausal women naturally have very high levels of estrogen, tamoxifen's weak estrogen-like effect in the bone isn't enough to replace the natural supply it's blocking. But for postmenopausal women, it is generally bone protective, completely unlike the AIs.
But while tamoxifen might spare the structural beams of the house, the aromatase inhibitors clearly do not. And that structural breakdown doesn't stop at the skeleton. It bleeds directly into the joints. Which brings us to arguably the #1 roadblock in these treatments, what patients often describe as the rusted tin man effect.
You're referring to Ames aromatase inhibitor-associated musculoskeletal syndrome.
Yes, AIMS. I was reading through the patient accounts you provided, and they just stop you in your tracks. There was one specific anecdote about a woman on an AI who was in so much agonizing joint pain, she had to wear rigid wrist braces to bed every single night just to get a few hours of sleep.
That's so common, sadly.
She was constantly dropping everyday objects like coffee mugs and keys because her hands were tingling and numb. She struggled to physically lift herself out of bed in the morning because the stiffness was so profound, and she even developed a visible, painful lump on her Achilles tendon.
It is a devastating deterioration of quality of life. And when you look at the mechanism, it makes perfect sense. Estrogen is what we call chondroprotective. It literally protects and maintains the health of cartilage inside your joints.
So when you deprive the body of estrogen so severely with an AI, the cartilage just degrades.
Rapidly, you induce significant cartilage loss.
Right.
But it's not just mechanical wear and tear. This biological stress triggers a massive flood of inflammatory cytokines in the body. And that leads to what the clinical literature calls tenosynovial changes.
Tenosynovial changes. Break that down for me.
It essentially means the synovium, the protective, lubricating sheaths around your tendons, become highly inflamed. At the same time, fluid starts accumulating abnormally inside the joints themselves. The actual joint space physically swells and degrades. That lump on the Achilles tendon you mentioned, that's classic tenosynovial inflammation.
It is the ultimate tragic irony. The exact daily pill that is actively saving your life, suppressing the breast cancer, is making your daily physical existence so agonizing that you actually want to quit taking it. And the reality is, people do quit.
They do.
The oncology data shows that 27% of patients discontinue their endocrine treatment entirely before the 5 or 10 years are up, and of that group, a staggering 68% stop specifically because of this joint and muscle pain, because of AIMS.
It's an impossible choice.
Yeah.
And we have to emphasize that this isn't a rare complication. AIMS affects anywhere from 50 to 82% of women on aromatase inhibitors. It is the absolute rule, not the exception.
Up to 82%. You're just trying to outrun cancer, and suddenly you're trapped in a body that feels like it aged 30 years overnight. But as visibly debilitating as the joint pain and the vasomotor hot flushes are, the clinical guidelines also highlight a completely unseen, silent struggle. A toll that these therapies take that no one on the outside can easily see or validate.
Yes, we need to discuss the urogenital and cognitive impacts. Medically, we group the physical side of this under GSM, or genitourinary syndrome of menopause. When the pelvic region is entirely starved of estrogen, the tissues undergo severe atrophy.
What is actually happening at a cellular level there?
Estrogen is responsible for maintaining the thickness, elasticity, and lubrication of the vaginal walls. It also regulates glycogen production. When estrogen plummets, the tissue thins dramatically. This leads to intense vaginal dryness, loss of elasticity, and profoundly painful intercourse. But beyond the pain, there's a cascade effect on the microbiome.
A microbiome. Like the bacteria.
Exactly, because estrogen drives glycogen production, and glycogen feeds the healthy lactobacilli bacteria in the vagina. Dropping estrogen starves the good bacteria. The pH of the environment rises, allowing harmful bacteria to overgrow.
Oh, wow.
Yeah, this alters the physical structure of the urinary tract, making these women highly susceptible to frequent, painful, and recurring urinary tract infections.
Wait, I'm confused about something here. Looking at the clinical comparisons between the drugs, it says AIs cause this severe GSM and dryness, but tamoxifen doesn't always have that exact same effect. Why would that be if they're both meant to block estrogen?
That's a great catch, and it brings us right back to the skeleton key effect of tamoxifen. Because tamoxifen is a selective modulator in postmenopausal women, it actually acts as a mild agonist on the vaginal tissues. It mimics estrogen locally.
Ah, so it acts like estrogen in the bones and the pelvic region.
Correct. So instead of inducing severe atrophy and dryness like an AI does, tamoxifen can actually stimulate the urogenital tissue. In some cases, it even causes a vaginal discharge rather than dryness. It's a completely different side effect profile, entirely dependent on how the specific drug is interacting with those local tissue receptors.
So what does this all mean when you step back and look at the whole picture? We've talked about the cellular key factories, the vanishing neutral zone of the brain's thermostat, the osteoclast demolition cruise, the inflamed joint fluid, and the altered microbiomes.
That's a lot.
It is a lot, but then you layer on the cognitive and emotional toll that patient accounts consistently highlight.
The brain fog is profound.
Exactly. Patients describe feeling like their brain is wrapped in cotton. They can't hold a thought. They forget words mid-sentence. They can't concentrate. And then there's the crushing bone-deep fatigue, which is massively compounded by sleep disruption. Because if your body temperature is spiking by 15 degrees and you are physically sweating through your sheets 4 or 5 times a night, you are not hitting REM sleep. You are chronically sleep deprived for years.
It is a systemic, relentless physiological assault. The drop in estrogen affects the serotonin pathways, which regulates mood, leaving patients incredibly vulnerable to clinical depression. You are compounding physical pain, chemical depression, and profound sleep deprivation.
It requires a monumental level of sheer psychological endurance. It's not just passively taking a pill, it's waking up every single day and actively choosing to induce a massive metabolic storm in your own body just to keep the cancer away, and doing that for 5, sometimes 10 years.
Which is why the term survivor
Mm.
really takes on a completely new, heavier weight when you truly understand what this maintenance therapy looks like on a cellular level.
Exactly. For you listening, being well informed on this topic isn't just about knowing the pharmacological difference between a receptor blocker and an aromatase inhibitor. It's about developing a much deeper empathy. If you know someone navigating the aftermath of breast cancer treatment, understand that when the active chemotherapy ends and their hair grows back, the battle is far from over. They might be right in the middle of a brutal, unseen menopausal marathon.
And this raises an important question, a final thought from the cutting-edge research to really chew on. The clinical data mentions a phenomenon known as brain adaptation. We know that for most women going through a natural menopause, or even those on these harsh endocrine treatments, the hot flushes and some of the severe neurological symptoms do eventually begin to fade over many years.
Wait, the brain eventually just resets itself.
It does. It adapts to the new hypoestrogenic or severely low estrogen state entirely on its own. The hypothalamus finds a new baseline.
It just takes a painfully long time to get there naturally.
Right, so the lingering question driving future research is this.
Mm-hmm.
If we know the brain can eventually adapt to a lack of estrogen, could the future of managing these severe breast cancer side effects lie completely outside of hormones?
Oh, that's interesting.
Instead of trying to give these patients tiny, risky bits of localized estrogen to relieve their symptoms, what if we develop non-hormonal therapies that simply chemically accelerate the brain's natural adaptation process? Can we teach the hypothalamus's thermostat to reset itself in a matter of weeks instead of years?
Wow. Bypassing the hormone debate entirely and just hacking the brain's adaptation timeline, that is a fascinating place to leave it. We started out talking about the expectation of a clean, simple cure treating disease like an X-ray with a broken bone that just gets fixed and forgotten. But the reality of breast cancer endocrine therapy is so much murkier, so much more biologically complex, and demands so much more from the patients who endure it. Thank you for joining us on this deep dive. Keep questioning the narratives, keep exploring the science, and we'll catch you next time.